Hello there. So this is the depression. This is the treatment of depression, as this must be probably the best looking couple of the world. But truth be told, they also had suffered major depressions, both of them, at least in one phase of their life. So what is depression? Depression is summed up by these acronyms, all the features of depressions. So if these features are present in somebody, then he is depressed. It is space dics, S for sleep changes and less sexual desire, P for psychomotor retardation, like feeling like nothing to do, feeling like doing nothing, and A means appetite, that is usually low appetite, and sometimes in atypical depression there may be high appetite, and concentration is low. Cognition means ability to do mental work or intellectual work is less, energy is less. And to diagnose major depression, the depressed mood should be present for at least 2 weeks, and there should be less interest, loss of interest, and G for guilt as well as hopelessness and worthlessness. This should be remembered as a phrase. There should be inappropriate guilt, hopelessness and worthlessness, and person may have suicidal thought, ideations and planning as well. These are the features of depressions. So if somebody has these features, then he is depressed. And what are the antidepressants? These are the drugs which elevate the mood in depressive illness. These are the drugs which elevate the mood in depressive illness. And what is the aim of depression treatment? It is remission of all the symptoms, and it takes at least 1 or 2 months for these symptoms to be treated by the antidepressant drug. And with bipolar depression, there is chances of switching into mania, which is a very dangerous situation. Therefore, depression treatment in bipolar illness is quite difficult. Psychotherapy, like changing the thought of the patient by his partner, by his by society, as well as the therapist, may be very much required in treatment of depression. So what causes depression? There are different hypotheses for causation of or the cause of depression. One is neurotropic hypothesis, which is related to the amount of brain derived neurotrophic factor. The more the amount of brain derived neurotrophic factor, less chances of having depression. And there are again neuroendocrine factors, which is related to the amount of cortisol, thyroid, sex hormone levels in the body. And again, the most famous and the important to us from the pharmacological point of view, monoamine hypothesis of depression. So monoamine hypothesis of depression says that in depressed brain, cortical and limbic in the cortex and the limbic system, amount of serotonin, norepinephrine and dopamine is less. And evidence to support this monoamine hypothesis of depression, which says there are monoamines, these three monoamines less in the cortical and the limbic serotonin, is that reserpine treatment which deplete the monoamines treat the depression. Reserpine treatment which deplete the monoamines causes depression. Reserpine normally deplete the neurons of monoamines, and this results in depression. This supports this monoamine hypothesis. And again, all the available antidepressants increase the synaptic availability of these above mentioned monoamines, so they increase the amount of these monoamines. So these two support the monoamine hypothesis. And moreover, the dopamine is correlated more with the stimulant action, then is more correlated with the stimulant action than with the depression. It is also more the dopamine, the person becomes more stimulated, and the person the depressed person is also less stimulated. So not to the mood, but more to the stimulant action dopamine is related. But these two serotonin and norepinephrine, they are more related to the mood of the patient, that is more of them good mood and less of them is depressed mood. So how to increase monoamine levels in the brain by drugs? This diagram depicts a place in the brain, maybe in the limbic and cortical centers. As we can see that the neuron secretes norepinephrine and serotonin, 5-HT serotonin. So when these are secreted, they are taken back into the neurons by these two transporters known as norepinephrine transporter and serotonin transporter, NET and ACT. And so what most of the antidepressant do is they inhibit this NET and ACRT. So when NET and ACRT are inhibited, then their amount in the brain in those centers increase. So this is the principle or the mechanism of action of most of the antidepressants. So what are the antidepressants we have? I have divided antidepressants based mainly on the chronology of discovery. First, in the 1950s, MAO inhibitors were invented. MAO is an enzyme, is a mitochondrial enzyme which stands for monoamine oxidase. This monoamine oxidase will degrade or metabolize the monoamines. So if monoamines degradation is prevented by inhibitors, it also has antidepressant effect. So we have monoamine inhibitors, hydrazines derivatives like phenylzines and isocarboxazide, and we have and back then we also use non-hydrazines like tranylcypromine, selegiline, moclobemide and chlorgyline. So these were used in the past, and later in the 1960s to till 1988, these tricyclic antidepressant TCA, tricyclic antidepressants were used, and they are of two types, tricyclic antidepressants. One is serotonin norepinephrine reuptake inhibitors, inhibitor TCA, and tertiary amines, and another is predominantly norepinephrine. It inhibits the reuptake of both norepinephrine and serotonin, but predominantly norepinephrine reuptake inhibitors TCA. These are secondary amines, structurally secondary amines. So in the tertiary amines, we have imipramine, clomipramine, amitriptyline and doxepin, and in the secondary amines, predominantly norepinephrine reuptake inhibitors, we have desipramine, nortriptyline and protriptyline. And these, if we see, imipramine metabolites is desipramine, and these tricyclic antidepressant TCAs and MAO inhibitors, which were first discovered, are now second and third line in the treatment of a major depressive disorder. These are only used rarely, these two drugs, TCA and MAO inhibitors, and their only place is treatment resistant depressed patient. If the patient after using many drugs still is having symptoms, then we use these drugs. These are second and third line, only treatment resistant depression it is used, these drugs are used. So what are the second generation antidepressants that were discovered in 1988, and ever since we are using them a lot? These are SSRIs and SNRIs. SSRI stands for selective serotonin reuptake inhibitor, that inhibits only SERT or serotonin transporter, and these are fluoxetine, sertraline, citalopram, paroxetine, fluvoxamine, escitalopram, and dapagliflozin. And in SNRIs, that is serotonin norepinephrine reuptake inhibitors, they differ from TCA in that they are not structurally tricyclic antidepressants. They do not have tricyclic rings. So we have serotonin norepinephrine reuptake inhibitors. We have venlafaxine, its metabolite desvenlafaxine, duloxetine, and milnacipran. So these we have in second generation antidepressants. So efficacy of second generation antidepressants is rated higher than the older TCAs, and its efficacy of these second generation is higher than the older ones. This is reversible inhibitor of monoamines and tricyclic antidepressants. So these have efficacy wise, these are better. And SNRIs, we have affinity of most of SNRIs tend to be much greater for SCRT than for NET. And SNRIs, they have affinity for both NET and SCRT, but more towards SCRT. So atypicals, and again time and again in different times we have these drugs also invented for depressions. They are 5S2 antagonists like trazodone and nifazodone, tetracyclics like mortazapine, amoxapine, maprotilene, unicyclics like bupropion, and others like mianserin, atomoxetine, tianeptine, and amineptine. So these are we have in store. So these are invented at different phases of time. They are also used for particular purpose that we will see later. So tricyclic antidepressants, these have these tricyclic rings, and actually imipramine was first synthesized from the phenothiazine chlorpromazine. So imipramine, so these we have tricyclic antidepressants, we have tricyclic rings, and mechanism of action is they inhibit both the norepinephrine transporter and SCRT or serotonin reuptake transporter, thereby increasing the amount of monoamines. And indications, I have listed 6 different indications of this TCAs, and they are for the major depressive disorders. They have second and third line because of their side effects and lethality, mainly because of that. And neuropathic pain like herpetic neuralgia, diabetic neuropathy, fibromyalgia, the cause of which is ascending corticospinal monoamine pathways, defect in them. So for those also we give this TCAs, and drug of choice is amitriptyline. And serotonergic TCA, that is basically more acts on SCRT like clomipramine, are used in obsessive compulsive disorder, enuresis. Enuresis means bedwetting even at the inappropriate age. So we use them, and they increase because decreased serotonin in brain seems to be the cause of these OCDs and enuresis. So these are good for clomipramine basically is good for obsessive compulsive disorder and bedwetting in children. And doxepin, which has high antihistaminic activity, is used for pruritus. And nortriptyline, so we have doxepin, since it is very much sedative, we use it in pruritus. And nortriptyline is used for smoking cessation, and imipramine and nortriptyline are used in attention deficit hyperkinetic disorder. So what are the ADRs of this tricyclic TCA? These are anticholinergic side effects, which are urinary retention, blurry vision, constipation, confusion, dry mouth. So these are seen, and especially they are more seen with tertiary amines, the tertiary amines, and S1 antagonism, which causes weight gain and sedation, and alpha 1 anti-adrenergic, which causes orthostatic hypotension, and more serotonin in gut means nausea, gastrointestinal upset, diarrhea, and more serotonin at spinal and supraspinal level means diminished sexual function and interest. Diminished sexual function and interest, more serotonin at spinal and supraspinal level means, and 1A, and they are equivalent to 1A antiarrhythmic agents, and as all antiarrhythmic agents are arrhythmogenic, they are also arrhythmogenic. I have listed 4 contraindications and precautions. One is these are given at night because they are quite sedating, and their dosing can be decided by the blood level or the therapeutic drug monitoring, and abrupt discontinuation can cause cholinergic rebound and flu-like symptoms. Abrupt discontinuation can cause cholinergic rebound and flu-like symptoms, and again increasing noradrenaline is not good for narrow angle glaucoma. So noradrenergic antidepressants are contraindicated in narrow angle glaucoma. So these are the contraindications and precautions for TCA. Interactions, I have listed 5 interactions. It has additive, anticholinergic, antihistaminic, and alpha 1 antiadrenergic effects. It potentiates the directly acting sympathomimetic amines, which is quite understandable. It potentiates the directly acting sympathomimetic amines, and by anticholinergic properties, they retard their as well as other drugs absorption by delaying gastric emptying, and these and pharmacokinetically speaking, these displace there are certain drugs like phenytoin, aspirin, and chlorpromazine. They displace tricyclic antidepressant from protein binding sites and cause transient overdose symptoms So they displace TCS from protein binding and cause overdose symptoms, and TCS are substrates for CYP2D6, and carbamazepine is the inducer of CYP2D6, and SSRI is the inhibitor of the CYP2D6. So they are understandable drug interactions. So there are 3 things that might happen in TCA overdose: lethal arrhythmias, lowering of seizure threshold, and depressing respiration. And for the arrhythmias of TCA, we prefer sodium bicarbonate drug, propranolol and lidocaine. So these are the drugs we use for the causing of TCA. SSRIs, so we have fluoxetine, sertraline, citalopram, paroxetine, fluvoxamine, escitalopram, and dapagliflozin. Their mechanism of action, these are SSRI, selective serotonin reuptake inhibitors. So they cause allosteric inhibition of serotonin transporter, and at therapeutic doses 80% of the activity of the SERT is inhibited. So why they are so popular? There I have listed 5 reasons. Because they are safe in overdose, and they have less side effects. They lack the affinity for histamine, acetylcholine, alpha 1 adrenoceptors seen with tricyclic antidepressants, and they are relatively of low cost, and they have broad spectrum of uses. Indications: major depressive disorder, anxiety disorders. There are many anxiety disorders that I will list in the treatment of anxiety. Bulimia nervosa, in which a person tends to eat a lot and purge and vomit a lot. Premenstrual dysphoric disorder, in some women there is excessive amount of premenstrual symptoms. Body dysmorphic disorder, some people are very dissatisfied with their certain body parts like nose, eyes, etc. Compulsive buying, some have this habit of buying something compulsively. Kleptomania, it is stealing for fun, compulsive pathological stealing for fun. And premature ejaculation, so this is also one of the indications for this SSRI. Premature ejaculation, it delays the orgasm, and the best drug for it is dapagliflozin. And ADR, it increases the serotonin in the gut. So what might be the side effects? Maybe diarrhea, maybe nausea, maybe gastric intolerance, constipation. So these might be the symptoms of the excessive amount of serotonin in the gut. Excessive amount of serotonin tone in the spinal cord and above, so it might cause sexual dysfunction like delayed ejaculation, anorgasmia, etc. And some patients gain weight, especially paroxetine. And short acting SSRIs especially cause discontinuation syndrome like paroxetine and sertraline, which is characterized by dizziness, paresthesias and other symptoms. And paroxetine can cause cardiac septal defects, so it is kept in category D. Other antidepressants are kept in category C for this pregnancy or pregnancy teratogenic classification of drugs. Interactions, I have enlisted 3 interactions. That fluoxetine and paroxetine are potent inhibitors of CYP2D6 isoenzymes, and one, for example, TCA is CYP2D6 substrate, so are the phenothiazines. Fluvoxamine, which is an inhibitor of CYP3A4. There are more than 50% of drugs are metabolized by CYP3A4, and when any serotonin drug is taken, it causes something known as serotonin syndrome, which we will see in the MAO inhibitors. So contraindications and precaution, fluoxetine and paroxetine plus TCA, which is CYP2D6 substrate, is contraindicated, which is for understandable reason. And diltiazem, which is CYP3A4 substrate, is also contraindicated with fluvoxamine. Otherwise, bradycardia and hypotension are seen. So few special things. Fluoxetine is the first SSRI, fluoxetine. So it has got the longest half-life and slower onset. Fluvoxamine is a short acting, and it is regarded as one of the best drugs for the generalized anxiety disorder, OCD. It is more towards generalized anxiety disorder and obsessive compulsive disorder, fluvoxamine. And paroxetine, it is short acting, so discontinuation reaction is more. Citalopram, it is more towards premenstrual dysphoric disorder, it is used for that, citalopram. And dapagliflozin, it is used for premature ejaculation. Now talking about SNRIs, I have listed 4 SNRIs. One is venlafaxine and its metabolite desvenlafaxine, and another is duloxetine, and another is milnacipran, and reboxetine. Reboxetine is newer selective noradrenaline reuptake blocker with weak effect in 5-HT reuptake. It is more reboxetine, is more towards NET block. So, a mechanism of action of SNRIs, they inhibit the SERT and NET as TCAs. As the name suggests, serotonin norepinephrine reuptake inhibitors, so inhibit both. But unlike TCAs, they do not have affinity for other receptors like alpha 1 receptors, maybe muscarinic receptors, histaminic H1 receptors, etc. So they are better tolerated. Indications: SNRIs are as effective as antidepressants, as TCAs, but they have less side effects. That's why they are preferred, and they are also working in even some resistant cases. And besides, they are good for neuropathies like post-herpetic neuralgia, chronic back pain, for which desvenlafaxine is the drug of choice, fibromyalgia, for which milnacipran is the drug of choice, stress urinary incontinence, for which duloxetine is the drug of choice, fibromyalgia is the one of the diseases in which there is seen especially in ladies, old ladies, associated with depression, in which there is muscle pain, bone pain, and post-herpetic neuralgia is the pain after these episodes of zoster goes, and stress urinary incontinence, in which you cannot hold the urine for long, and vasomotor symptoms of menopause like hot flashes and generalized anxiety. So these are the 4 indications of SNRIs. Now, contraindications and precautions, I have listed 3. Combination with MAO inhibitors are contraindicated, like all serotonergic antidepressants, for the fear of serotonergic syndrome. Hepatic impairment. In hepatic impairment, we do not use duloxetine because it is hepatically metabolized, and it is also abrupt withdrawal can cause discontinuation symptoms like paresthesia, headache, and all that. Interactions, they are contraindicated with combination with MAO inhibitors for the fear of serotonergic syndrome, and ADRs like have noradrenergic effects, therefore can increase blood pressure, heart rate peripherally, and centrally they can cause CNS activation like insomnia, anxiety, and agitation. And venlafaxine has cardiac toxicity more with venlafaxine. And SNRIs have been associated with discontinuation syndrome resembling that of SSRI discontinuation. So these are the adverse drug reactions of SNRI. So talking about MAO inhibitors, MAO is the mitochondrial enzyme involved in the oxidative deamination of monoamines or the biological amines. There are MAO A and MAO B, and MAO A is involved in monoamines like norepinephrine, serotonin, dopamine, but MAO B is not involved in that. MAO B is present in the brain, and it is more concerned about dopamine. So MAO B inhibitor is good for Parkinson's disease to increase the dopamine level in the brain, and MAO A inhibitors are better for depression because they increase the amount of norepinephrine, serotonin, and dopamine. So these MAO inhibitors are unpopular because they have toxicity and potential lethal food and drug interactions that we will see later. Its mechanism of action is inhibiting the normal enzymatic degradation of monoamines, norepinephrine, dopamine, and serotonin, and they are hit and run drugs. That is, their activity does not depend upon the plasma level. Indications: they are only for those depressions which are unresponsive to antidepressant these days. And interaction of MAO inhibitors is very important. One is serotonin syndrome. MAO inhibitors plus serotonergic agent can cause life-threatening serotonin syndrome. So what is the cause of serotonin syndrome? It is overstimulation of 5-HT receptors in certain part of the brain like central gray nuclei and medulla. And symptoms of serotonin syndrome is it causes the triad of cognitive, autonomic and somatic effects. Cognitive means it is concerned with the intellect or the brain. So it is delirium. Delirium means to be excited and confused. So it can go from cognitive delirium to coma. Autonomic means related to the blood pressures, hypertension, tachycardia, diaphoresis, perspiration. And somatic related to the body like excessive reflex, myoclonus, a kind of abnormal body movement, and tremor that we appreciate in the hand. So these are the symptoms of serotonergic syndrome. One is cognitive, autonomic and somatic symptoms. So Cheese reaction or the tyramine pressure effects is the second interaction. Cheese reaction or tyramine pressure effect. So what happens is when we take the MAO inhibitors, it go and reside in the intestinal wall and liver as well. So when we take the tyramine containing food like cheese, tap beer, soya products, dried sausage, etc., the tyramine, because of the MAO inhibitor drugs in the gut, tyramine in them escape the metabolism there and reach the systemic circulation. In the systemic circulation, tyramine indirectly displaces and release large amounts of noradrenaline from adrenergic nerve endings. This huge surge in noradrenaline in the blood causes hypertensive crisis and cerebrospinal accidents. This huge source of noradrenaline in blood as released by tyramine, which displace and release those noradrenaline from adrenergic nerve endings, cause excessive noradrenaline in blood, and this results in hypertensive crisis and cerebrovascular accidents. Similarly, other sympathomimetics, over-the-counter preparations like pseudoephedrine, phenylpropanolamine can also cause similar cheese-like reactions. So this is about cheese reaction. So what are the ADRs of MAO inhibitors? Most common is of MAO inhibitors is orthostatic hypotension and weight gain. And MAO inhibitors like selegiline has amphetamine-like metabolites, so they cause CNS stimulating effect like stimulation, insomnia, restlessness. And hydragenes and tranylcypromine, which is non-hydrazine, can cause anorgasmia. And with an overdose with MAO inhibitors, with an MAO inhibitor can cause serotonin syndrome like symptoms, as I mentioned, somatic, cognitive, autonomic symptoms. This can cause with MAO inhibitors, and sudden discontinuation of MAO inhibitors can cause psychosis, excitation and confusion. So 5-HT antagonists, these were used much till 1980s, like MAO inhibitors, like tricyclic antidepressants, and ever since the manufacture of SSRI and SNRIs, they have gone into oblivion. Mechanism of action of this 5S2 antagonist is they cause 5S2A receptor blockade, which is associated with anti-anxiety, antipsychotic and antidepressant effects. Nifazodone also is the weak inhibitor of SCRT and NET, and trazodone is also weak inhibitor of SCRT. So these are the mechanism of action of heterocyclics, nifazodone and trazodone, or 5S-T2 antagonist. So I have listed two indications of 5S-T2 antagonist. These are anxiety and on-label hypnotic interactions. So nifazodone is the potent inhibitor of CYP3A4, so increases the level of triazolam and simvastatin, and ritonavir and ketoconazole increases their blood level because they are also themselves the CYP3A4 substrate. And regarding the area of trazodone, trazodone causes presynaptic alpha blocking. It also has S1 receptor blocking effect, therefore sedation, though mild, and it also causes priapism, which is painful erection, and nifazodone causes hepatotoxicity. Regarding tetracyclics, mirtazapine, amoxapine, maprotilene, they are commonly prescribed in current practice when other are unresponsive. Talking about amoxapine and maprotilene, they resemble secondary amine TCase structure and side effects. Amoxapine and maprotilene resemble secondary amine TCase like desipramine. So TCase structure and side effects, so they resemble secondary amine TCase structure and side effects, and they share more drug interactions common to TCA. Again, they are also CYP2D6 substrates, tetracyclics, amoxapine and maprotilene. And regarding amoxapine, it is the metabolite of loxapine, which is a heterocyclic antipsychotic drug. So it has got D2 blocking activity, and so is used in psychotic depression, and it has got D2 blockade, so Parkinsonian syndrome as a side effect. Regarding mirtazapine, it blocks presynaptic alpha-2 autoreceptors on NA neurons and heteroreceptors on 5-HT neurons, thus enhancing norepinephrine and serotonin release. This is also known as NASA, mirtazapine, because noradrenergic and specific serotonergic antidepressant, because it is noradrenaline and specific serotonergic antidepressants. It has S1 blocking effect but no antipsychotic and antidopaminergic effect, and occasionally it is used for hypnotic as an hypnotic, but chronic use can cause weight gaining. Amoxapine and maprotilene interaction, since these are similar to TCS, they are CYP2D6 substrate, so not with fluoxetine, and it has additive anticholinergic and antihistaminic properties because it is similar to TCAs. Unicyclics, bupropion, it structurally resembles amphetamine, so it has CNS activating property. Bupropion, it inhibits norepinephrine and dopamine reuptake. This is probably the only one that inhibits the dopamine reuptake, so has excitant rather than sedative property. I have listed 5 uses. It causes reduced urge to smoke by augmenting dopaminergic reward function. and it is also used for treating obesity, and it is used for the sexual adverse effect of SSRIs, and it is also used for major depression, especially seasonal or winter depression. And off label, it is not approved, but it is also used for attention deficit hyperkinetic disorder. Contraindications and precaution of bupropion: it lowers the seizure threshold. It is not good for anxious patient bipolar affective disorder and eating disorders. It is not good for that. Interactions: it is avoided in patients taking MAO inhibitors, maybe for the fear of serotonin syndrome. And ADR, it is metabolized into amphetamine like compound, so it causes agitation, insomnia, and anorexia. There is something known as atomoxetine. It causes selective norepinephrine reuptake inhibitor. It causes selective norepinephrine reuptake inhibition, atomoxetine. So it is used for attention deficit hyperkinetic disorder. There are something known as tianeptine and amineptine. These are used to increase rather than to inhibit 5-HT uptake. So, and neither sedative nor stimulant, but their mechanism of action I cannot say how. Now, regarding anti-anxiety drugs, first of all, what is anxiety? It is an emotional state, unpleasant in nature, associated with uneasiness, discomfort, and concern or fear about some defined or undefined future threat. Emotional state, unpleasant in nature, associated with uneasiness, discomfort, and concern or fear about some defined or undefined future threats. Some degree of anxiety is the part of life, and treatment is needed when it is disproportionate to the situation and excessive. So, what are the different anxiety disorders? Post-traumatic stress disorder, when after seeing some life-threatening incident or undergoing through the life-threatening incident, one has repeated flashback of those situations, hyper-vigilant, and remembers those situations again, re-experience those situations again, cannot sleep, and that disturbs his day-to-day life, and avoids the situation in which such things could be repeated. This is known as post-traumatic stress disorder. Obsessive compulsive disorder, in which a person feels like performing something again and again, feels like that is obsession, and go and does that again and again, that is compulsion. So this, and if a person does things and does something again and again, then this is known as obsessive compulsive disorder. Social anxiety disorder, like a person cannot expose himself in the society, and that hampers his personal, financial, occupational life, then that is known as social anxiety disorder. Generalized anxiety disorder is like free floating worries about something, about different things all the time. This is known as generalized anxiety disorder. Panic disorder, exposure or just thinking of something causes excessive amount of anxiety in form of increased blood pressure, heart rate, etc. with or even thinking of those things is known as panic disorder. So these things need to be treated. So what are the anxiety drugs we have? We have SSRIs and SNRIs. We have benzodiazepines, like different listed here: diazepam, chlordiazepoxide, oxazepam, lorazepam, alprazolam, azapirones, buspirone. This is often used, or at least written in literature. Sedative antihistaminics like hydroxyzine, and beta blocker. This is very much used, propranolol. SSRI and SNRIs are used for the chronic anxiety disorders but are not good for the acute anxiety. These are the drug of choice for the post-traumatic stress disorder, obsessive compulsive disorder, social anxiety disorder, generalized anxiety disorder, and phobic disorders, in which BZDs or benzodiazepines, though effective, carry abuse potential on long-term use. So when they have to be treated for the long term, then we use SSRI and SNRIs, especially SSRIs. BZDs, though effective, have side effects. Benzodiazepines, they act quickly, but others take time to act. But panic attacks are initially treated rapidly with BZDs, but they are not suitable for long term. Panics, because the person is panicking, so we have to treat him acutely with diazepam or alprazolam. Anxiety associated with depression, also we treat with benzodiazepine. Anxiety associated with depression, alprazolam, we use alprazolam for that. Now, buspirone pharmacology, it is the first azapirone group of drug. Its mechanism of action is partial agonistic action on 5-HT1A receptors. Partial agonistic action on 5-HT1A receptor. So it has used in mild to moderate generalized anxiety. It is used for generalized anxiety disorder, and it is preferred because it does not produce sedation or cognitive and functional impairment, and no dependence. No sedation, cognitive, functional impairment, and no dependence. ADR of buspirone, it has minor side effects, and it takes at least 2 weeks to work. Minor side effects are dizziness, nausea, headache, lightheadedness, and rarely excitement. Interactions, it may cause a rise in BP in patients with MAO inhibitors, most probably due to serotonergic syndrome. Contraindications of buspirone, it is said to be contraindicated in operating machinery, motor vehicles. It is a statutory directive, though it doesn't happen most of the time, but it is written, so it is contraindicated. Now, regarding hydroxyzine, it is used for pruritus and urticaria for its sedative action. And regarding beta blocker, propranolol, in anxiety, many symptoms of anxiety like palpitation, rise in blood pressure, shaking, tremor, gastrointestinal harrowing, etc. are due to sympathetic overactivity. Propranolol help anxiety patients by cutting these symptoms and providing symptomatic relief. So it is valuable in stressful situations like examination fear, unaccustomed public appearance, performance and situational anxieties, and phobias. So these are quite effective in these situations. Thank you.